Hello, everybody. This is Dr. Kapil Gangwal from Jaipur. I'm going to be talking on the lateral humeral condyle fractures and their complications which are associated with it. Well, as we know, there are numerous complications associated with the lateral condyle humeral fractures, and we're going to look at some of the factors which are responsible for causing these complications, as well as we'll try and look at some of the complications specifically and see how they affect the function of the child with the lateral condyle fracture. Well, there are some factors which are related to the fracture itself. As we know, it's a physeal injury and goes across the growth plate. Mostly it's a Salter-Harris 2 fractures, which have lesser tendency to cause problems and complications, but occasionally it's a Salter-Harris 4 fracture, which has a higher chance of giving rise to problems in these children. It's an intra-articular fracture, and it can cause intra-articular incongruency, which can pose numerous problems. Occasionally, it's an avulsion injury, which causes the fracture to be unstable and predisposes the fracture to secondary displacement, which again can cause various problems in the management. Also, the fracture has, the lateral condyle has a precarious blood supply, which comes from a small area on the posterior side and predisposes these fractures to avascular necrosis. Well, there are some problems which are related to the management as well. These fractures are often missed and hence present later, which causes poor outcomes and complications. There's a problem of secondary displacement, as we spoke, because of the inherent unstable nature of the fracture. Also, there may be iatrogenic problems like inadequate reduction, inadequate fixation, and inadequate immobilization, which can all cause problems. Well, this is a study which came out in 2018 from the National University Hospital in Singapore. They looked at 445 studies, and it's a systematic review. They had over 2,400 patients, and they categorized all these children based on the complications they had and the percentages of complications in each category. They looked at union problems, carrying angle issues, valgus, varus, deformities, range of motion loss, other complications like the lateral spur, fishtail deformity, avascular necrosis, physeal closure, and so on. And we'll look at them later in this talk one by one. Well, the big problem is of a misdiagnosis. These fractures are difficult to pick up, and this is seen in about 16% of these cases. If we look at this X-ray, we find that there's a swelling on the lateral aspect of the elbow that we can appreciate, but there's no clear fracture line evident. And if you really take the internal oblique view, you can see the fracture in profile, and this has been shown by Quan Song in a seminal article in which he showed that about 70 to 75% of these children who had this fracture actually showed a higher degree of displacement when they compared it to the anterior-posterior projection radiograph and the internal oblique radiograph. So this is an important um, radiographic projection which we must all be aware of and prevent and missing the diagnosis of these fractures. Well, the other association that we often think of, that if there is associated injury, these fractures will have a poor outcome. And the most common association is that of an elbow dislocation. And the study looked at associations of elbow dislocation with lateral humeral condyle fractures and found that actually the elbow dislocation did not predispose these fractures to higher complications. And once the elbow dislocation was reduced, the lateral condylar fracture behaved exactly as though there was no elbow dislocation present. However, if there were fractures of the olecranon, forearm, medial epicondyle, or the condyle, which are the other commonly associated fractures, there was a higher chance of getting into complications and problems. Looking at fracture patterns and displacement, the Jacob 3 or the more displaced fractures have a higher chance of getting into complications, although the fracture pattern itself did not really matter as regards to complications. Weiss in this study showed that a 4 millimeter displacement at the articular surface or articular step off of more than 4 millimeters, if present, predisposed these children to a higher complication rate as compared to those who had a lesser displacement at the articular surface. When we look at how these fractures were fixed, the screws fared better as compared to K-wires, and probably because there was more compression at the fracture site with the screw fixation as compared to the K-wires. And there was a lesser chance of getting into a lateral condylar prominence or a fishtail deformity in the children who had a fixation of the fracture with a metaphyseal screw. Well, the most common complication with these fractures is the lateral spur. It is seen in about 27.3%, and some studies have reported incidence of as high as 70%. Well, why does the lateral spur form? It's formed by periosteal new bone, which is secondary to the periosteal flap being displaced on the lateral and posterior side. And it's because of the lateral and the lateral fracture displacement and the rotation of the fragment. It is seen as well in the operative and the non-operative group, although the spur is bigger and more hypertrophic in those children who had a surgical intervention, because probably because of the dissection that one does during the surgery. And when the spur is large, it can cause a pseudovarus deformity, which actually accentuates a cubitus varus if it's already present. Well, delayed union is another problem associated with this fracture. It's seen in about 0.9% cases, and if the fracture is not united by 8 weeks, it's termed as a delayed union of the fracture. It's secondary to late diagnosis and inadequate management, mostly seen in conservatively treated fractures. So the minimally displaced fractures actually get a secondary displacement and predispose the fracture to go into a delayed union or a non-union. Also, if the fracture was operated upon and the reduction was not accurate, it may go on into a delayed union. Well, the study which came out from Canada shows that percutaneous screw fixation of these minimally displaced delayed unions actually works well. And the prerequisite is that they should have a fair range of motion on the affected site, and the delayed union should not be of more than 15 weeks from the onset of fracture. Well, non-union is the other big problem. It's these fractures are termed as being ununited if the fracture is not healed by 12 weeks from onset. Incidence is about 1.6%. The predisposition is if the patient is not brought on time, injury got missed, the child got casted and the fracture displaced in the cast, so secondary displacement, which was not picked up. The cast was removed too early, and the fracture displacement was more than 2 millimeter but not fixed. And this has been alluded to in this article by Quan Song and Peter Waters, who showed that these are the fractures with more than 2 millimeter displacement are the ones which really need to be fixed to prevent getting into a problem of non-union. Non-unions can be subdivided into early or late. So the early non-unions are the ones which are about 12 weeks to a few months from injury, while the late non-unions are the ones which go on for several months to years from the onset of the fracture. You can further subdivide them into those with angular deformity or without the angular deformity. The ones without the angular deformity are usually asymptomatic and have minimal fracture displacement. And those with the angular deformity are seen after the ones which are more displaced, like the Jacob 3 or the Milch 1 fractures. They are the ones which are symptomatic, and the fragment has a tendency to progressively migrate proximally, causing progressive valgus deformity and late onset ulnar nerve palsy. The dilemma really is to leave them alone or to reconstruct. If you leave them alone, there is a problem of instability, progressive deformity, pain, and late onset ulnar nerve palsy. If we embark on reconstruction, we risk stiffness, avascular necrosis, and worsening pain. The timeline for developing symptoms has been alluded to in this publication by Satoshi To and Kenji Tsubo. They showed that the range of motion usually improves till about 1 year from the onset of symptoms, from the onset of the fracture. Pain and instability actually starts to show its manifestations by 9 years. Ulnar nerve dysfunction comes in at an average of about 12 years from the onset of fracture. And those who had increased valgus deformation of the elbow had a higher chance of getting into ulnar nerve dysfunction issue. They looked at the two subtypes, the Milch 1 and the Milch 2 fracture patterns, and they found that the Milch 1 fracture patterns actually had a worse outcome with a higher valgus deformity and more instability and pain. And they recommended that one should go and fix the type 1 non-unions early to prevent progressive deformity and disability. Flynn made two publications, one in 1975 and one in 89, and alluded to the subtype in which the fracture displacement was less than 1 centimeter from the joint surface and had an open and viable lateral condylar physis. And they showed that in these subtypes, with the fracture or fractures without the proximal migration, and the fragment was in a good position, you could just fix these fractures with a screw and add a bone graft as and when needed, and these went on to do well. The important thing was that the screw fixation should be through the metaphysis and not through the epiphysis, and one should not try and get the articular surface to get aligned, because that requires a lot of dissection, and that would predispose to problems. The late non-unions are a different subgroup, and one really needs to follow a la carte approach. The fragment needs to be fixed if there is instability and pain. If there is ulnar nerve dysfunction, it needs anterior transposition of the ulnar nerve. One needs to add an osteotomy. For cubitus valgus deformity, the deformity is over 20 degrees. One can do this in a staged manner as proposed by Papandera and Waters. In the first stage, there is an in situ screw fixation of the fracture with or without a bone graft and an anterior transposition of the ulnar nerve. In the second stage, there is a corrective varus osteotomy, which is typically done 6 months later. The osteotomy can be a pure angulation correction or angulation or translation correction depending on the degree of deformation. Tyne in 2005 showed that all this could be done safely through at a one-stage procedure, and he proposed an in situ screw fixation, a dome osteotomy, and anterior transposition of the ulnar nerve all through a posterior approach. Well, what does one expect after reconstruction? The instability and the pain resolve. The ulnar nerve symptoms will typically resolve. The problem comes with range of motion. If it tends to typically increase when the range of motion is restricted, but there is a problem in long-standing cases, and especially when you try and combine all the procedures together. The Milch 1 fractures have worse outcomes, especially because the fragment is small, it is more displaced, and there is more deformity to correct. The younger children fared better as compared to the older children. Now, this is a case which shows a 11-year-old girl with a long-standing non-union. You can see the cubitus valgus. You can see the bump on the medial side. That's the fracture. It's not very displaced from the articular surface. A one-stage procedure was planned in which dome osteotomy and an in situ fixation and anterior transposition of the ulnar nerve was done. That's a few months post surgery. That's about 3 months post surgery. The deformity is corrected, and she has a fair range of motion, although the terminal flexion is restricted. Well, malunion is seen in about 1.6% cases. It's caused by secondary missed secondary displacement or a malreduction, and it predisposes to reduced range of motion at the elbow and sometimes a deviation in the carrying angle at the elbow. Cubitus valgus seen in about 6.1% cases, again caused by non-union, malunion, or AVN. And the ones which are really progressive are the ones which are troublesome, and they cause the tardy ulnar nerve palsy. Cubitus varus is enigmatis deformity in this subgroup of patients. One would not imagine getting a cubitus varus in a lateral condyle humerus fracture, but it's actually a deformity which is more common than the cubitus valgus and is seen in about 7.8% cases. Some reports have shown incidence of as high as 40% in some series. It's caused by hyperemia or growth stimulation of the lateral condyle, and the deformity is usually mild, asymptomatic, and can also show some resolution over time, as alluded to in Skak's paper. And this has been kind of countered, this view has been kind of countered by a recent publication in 2020, which looked at 12-year follow-up of these patients, and they found that the deformity which was present a few months or years after the injury really did not show too much change over time. Well, fishtail deformity is another peculiar complication of these fractures. It's seen in some other fractures as well at the lower end of the humerus in children. There are two patterns of deformity as which one can see. One is a kind of a gentle U kind of a curve of the epiphysis, while one is a sharp kind of a deformity of the epiphysis. It's seen in about 14.3% cases. It's caused by medial instability at the fracture site, at the junction of the trochlea and the capitulum. It can be caused by partial growth arrest in the central portion, avascular necrosis in that region, or a malreduction or lack of compression across the articular surface. And it's mostly seen in the Milch type 2 fractures because that's the fracture which courses through the trochlear surface, and in the more displaced fractures as well. So luckily, the fishtail deformities, most of these children are asymptomatic. They can have mild carrying angle deviations or range of motion restrictions. And in the long-standing cases, there has been some indication of predisposition to degenerative arthritis as well. The reduced range of motion at the elbow is another problem which is seen with some of these fractures. It's actually probably the lateral condyle humerus fractures are responsible for the maximum amount of range of motion restriction compared to any other fracture around the elbow in children, where the flexion losses are higher than the extension losses. And again, the predisposition is because of inadequate reduction, multiple K-wire fixation compared to screw fixation, and delayed presentations. Well, the limitation, luckily, is again not very severe, and the children are largely functional and asymptomatic, and there has been some indication that they may show improvement of the range of motion over time, though again this has been refuted by the study of a long-term follow-up of these children which came out in 2020. Well, physeal arrest is possible with these fractures, not very common. About 5.4% children show physeal arrest. Usually it's not very evident. These are all asymptomatic children because there's not a huge amount of growth which happens from the lower end of the humerus. It can cause a cubitus valgus deformity and a fishtail deformity if the arrest is in the central portion of the growth plate. Well, neurological deficits basically boil down to ulnar nerve palsies and unstable non-unions with progressive valgus deformity. And this paper by Masada show that the treatment is of this problem is an anterior transposition of the ulnar nerve, and just correction of the deformity by a supracondylar humeral osteotomy will not take care of the problem. Well, other complications are pain, heterotrophic ossification, infection, and symptomatic implants. And in long-standing cases, some of these children may end up having osteoarthritic changes when they reach adulthood. Well, to summarize, numerous complications are associated with lateral condyle humerus fractures in children. Sticking to principles of diagnosis and management can minimize these complications. Long-term evaluation of complications has not shown much improvement over time in function in these children, and delayed union, non-union, cubitus valgus, and ulnar nerve palsy may require secondary interventions in these children. Thank you very much for your attention.